Jyoti, please, you can start.
Okay, take two. I'm going to talk about what surgeons need to know about SARS-CoV-2, and we'll just talk about the virus first in terms of survival and how can you kill it, and then how does it spread and where do you find it in patients. This pictorial just gives you a sense of the size. It is quite large for viruses, but certainly smaller than bacteria and red cells. So this table shows you the comparison between SARS-CoV-2 as with influenza, SARS, and MERS, all of which are similar in that they're respiratory viruses. So SARS-CoV-2 is larger than SARS was, so it's 125 nanometers versus 80 to 90. The RO is very similar actually, and RO is something that changes, so with social distancing it will definitely fall. The case fatality rate, as you can see, is quite low compared to SARS and MERS, but higher than influenza. And the case fatality rate really is reflective of how many people are being tested in your community. So the more you test, the lower it gets, just because you'll get the more mild cases. And definitely SARS is a pandemic, as we all know, similar to what H1N1 in 1917 was. So in terms of survivability, this paper was published in the New England Journal. It was an experimental study looking at SARS-CoV-1 versus SARS-CoV-2 and how are they different, because clearly their infectiousness and the time of infection range is different. So what they found under different environmental conditions is that SARS-CoV-2 is fairly stable on plastic and stainless steel up to 72 hours. And we know this about viruses. They tend to survive easily on flat, hard surfaces, and they don't survive well on soft and rough or uneven surfaces. So for copper, it was 4 hours, and for cardboard, it was up to 24 hours, so quite a bit shorter. Even though it survived 72 hours, the viral load did drop over those 3 days significantly. And when they generated aerosols in the lab, they found that the half-life was about just 1 hour. So not super long. So overall, the SARS-CoV-2...
I make you host, so you need to accept the people.
Overall, SARS-CoV-2 was very similar to SARS-CoV-1 in terms of its survivability on surfaces. So the fact that it's more infectious early on is more related to host factors, not so much the virus itself. The hospital-grade cleaning products all work very well, and here's a table that shows you that. We use alcohol on our hands, and it's because chlorhexidine is not effective. So we always want to use alcohol, or good old soap and regular detergent works very well, and is actually preferred. So quaternary ammonium compounds also work well. So pretty much all the hospital-grade products are very effective at killing it, and you can see from the exposure times it happens very quickly. 30 to 60 seconds. We always recommend at least a 1-minute contact time. SARS, as you know, SARS-CoV-2 or COVID-19 is spread mainly by droplet, but there is some aerosol generating procedures where you see the aerosol transmission. And the difference is really the size of the particles that are coming out of your mouth. And so droplets are larger, they just drop to the floor. They do contaminate the environment, and that's where we see what we call fomites spread. So things get contaminated. It's very common with bacteria as well, and that's why cleaning in hospitals is so important. One thing to point out is that similar to SARS and MERS, actually, there's more super spreader events. So generally one patient won't spread it to too many, if at all, but then there's times where there's a patient who's infected or a person who's infected who spreads it to many people, and you'll hear about those events. And we don't understand them well, but they tend to be the ones that are driving the epidemic. So, sorry, in terms of masks, I think everyone knows if it's droplet, surgical masks are quite protective, but for aerosol, you need the higher grade N95 masks. So here's a list of the aerosol generating procedures. These are the times that you really do want to be wearing an N95 or a PAPR. So they're broken up into anesthetic versus surgical. I think for surgical, the other concern is when you're doing laparoscopic surgery and also any kind of aerosol generating procedures. But the way to think about that is, where is the virus in the patient's body, and is it in the fluids that you're going to be encountering? So here's a paper from China where they looked at about 205 patients, and they collected over 1,000 specimens at the time they were ill with COVID-19. And it's a respiratory virus, so the main place it's found is in the respiratory tract. BAL and sputum have the highest rates of finding the virus. After that, besides respiratory tract, we see it in the feces. We haven't really proven fecal oral transmission, but it's certainly something to think about. Blood, though, most patients are not viremic. The numbers are between usually 1 and 5%, at the most 15%, but in this paper it was just 1%. And here's the diagram from the paper, and I circled the brown triangles because that's the feces. So they did find detectable levels of virus, and when they looked at 2 stool samples, they could find live virus. So we do worry more about stool being contaminated with the virus than blood for sure. In terms of nosocomial transmission, and this is something we worry about in our hospitals, is if patients are together in a cubicle, what is their risk of getting it from another patient? Of course, our goal always is to separate patients and not put them in an open cubicle. But to look at that, there hasn't been any studies that have looked at it, but we can look at secondary attack rates in families. And CDC and a study in Japan, both looking at it, found about 10 to 15% secondary attack rate. So and we see family clusters, and again, most of the time, all of the family members don't get it. So the secondary attack rate is about 15%. In terms of healthcare workers getting it, Hong Kong had a study where 2.7% of healthcare workers had unprotected exposure, and none of them were infected. And then I'll show you one from Singapore in which also the same was true. What about environmental contamination in terms of a patient's room? So NCID here in Singapore did look at that. They had 2 patients, one of which had a fairly high viral load, and they looked at samples in the environment before and after cleaning. They found a lot of virus where you'd expect it, around the patient bed and things, but also in the toilet and the bathroom areas, which speaks again to seeing it in the stool. But when they did the cleaning and did repeat swabs, they didn't pick up any virus. So the cleaning was very effective. In this study, they also swabbed some gowns and some shoes, and the front of the shoes, one out of the 2 had virus, but it didn't track out to the anteroom or the corridor at all. So this is a paper that was published, a letter from Changi. It was an inadvertent exposure of a patient who was intubated. It was a difficult intubation, and they didn't find out he had COVID till after extubation. When they looked at the 41 healthcare workers who were exposed, most of them were wearing a surgical mask because that had been our policy, and only some were wearing N95s. And when they followed them, both at the time they sent them home for the 14-day quarantine and at the end of the 14-day quarantine, none of the workers swabbed positive and none of them fell ill. So again, it speaks well to the fact that good hand hygiene and even surgical mask works, but of course we do recommend N95s for intubations. This is a letter to the New England Journal that hasn't been published, but I just found it. It's preprint, and actually it's been accepted, it just hasn't been published. But basically in China, of their 77,000 cases, 4.4% were healthcare workers who got it on the job, and 23 of them died. You can see the average age with the range of 29 to 72, and many of them were actually rehired physicians, older physicians. There were 8 surgeons and 3 were ophthalmologists. Interesting, none were infectious disease doctors and none worked in an ID hospital. And again, I think this speaks to when patients are segregated at the time of entry, so in triage to the right rooms, and when people are wearing their PPE, it is quite effective, and the PPE does work. So on to talking about the clinical spectrum of COVID. The things to think about are what is the average incubation time. So if someone got exposed, usually when do they get sick? What is the time that they need to be intubated if they do? And then what are the risk factors for morbidity and mortality? And then who should you think about it in? I think everyone knows the numbers overall, and these have held true from every country so far, that 85% of patients do fine and really don't get very sick. 15% do go on to require some kind of oxygen or other support. And then 5% become critically ill where they really have multi-organ failure and require intensive ICU care, of course, and often those are the groups that have a mortality. So the average incubation period is about 4 to 5 days. It can be up to 14 days, but usually it's just within 4 to 5 days. It can be as early as 1 day, but usually it's 3 to 5 days. The average time for really getting sick is day 9. That's the tricky part. Patients can look well and feel well for the first 6 days. And then they come in and get tested and they say, but I'm fine. And 2 days later, they crash. So that's the time to worry. Morbidity and mortality is definitely older age. It's much, much higher in people who are older, 65 and above. And cardiac disease is a risk factor. Obesity is becoming a huge risk factor, and diabetes. So who should you suspect? We always say, you know, just like anything else, it's a infectious disease. So ask about contact with a known case, recent travel, family members being sick. It's always good to ask, or close contacts. And then are there any clusters, and have they been around those clusters? So just to give you a sense, COVID can be really very severe or very mild when it presents. This was a patient who had presented 2 days earlier and actually just had a mild fever, but a normal exam. He came back 2 days later, and at this point reported that his wife was also having a fever. So there's a family member who's sick. And at this time, he had a temperature of 37.8 and crackles on exam. And when labs were done, they were quite significant. He had elevated CRP, liver enzymes were a little bit elevated, and LDH was high. So he did not have any known contacts other than his wife was sick, but he ended up progressing fairly quickly and ending up in the ICU. This was his x-ray at the ER, the second visit, and you can see he had an infiltrate here and here. It's quite subtle, which is often how these x-rays are. Now, this patient is a 23-year-old who was very well. She came in because she had a cough for 1 day, but also she came in because her employer had just been confirmed. So because she had a cough, she decided to come in. Her labs were completely normal and her chest x-ray was normal, but she did swab positive. This is another patient who was admitted and tested positive, and you can see her x-ray. You can see these sort of splotchy infiltrates even bilaterally, and she progressed very rapidly, which often happens. So she came in around day 7 of illness and then progressed pretty fast. So the symptoms of COVID are quite unusual in that they can be almost nothing to just, you know, loss of smell and loss of taste. You would have heard about that being quite a common newly recognized phenomenon that does happen with other viruses, but for COVID, it seems to be more prominent. Patients can just have a dry or itchy throat or a sore throat, dry cough, blocked nose, runny nose, very mild URTI symptoms. Also, though, there can be systemic symptoms just like influenza with fatigue, myalgias, headaches. Sometimes patients have red eyes. Diarrhea happens not infrequently. Sometimes it's just twice a day. Other times it's the main manifestation, as well as nausea and sometimes confusion. So in terms of the signs to look for, patients often have crackles. So even before the chest x-ray shows much, on exam you will hear crackles, either unilateral or bilateral, and you should definitely listen for that. Red eyes is not uncommon, higher respiratory rate. They can desat with movement or get short of breath with just walking to the bathroom. Much less common could be a presentation of confusion. The spectrum, again, like I said, is broad from ARDS to pneumonias to AKI. We're seeing more and more myocarditis and MI, and you would see that reported in the literature. And patients do have this very hyperinflammatory picture when they become sick. So this is a postulated mechanism where early on, it's mainly viral, with a higher viral load, more fevers, and then as later, and this is usually about day 9, as I said, that's when the host inflammatory response can kick in. But not everyone gets this. The majority, again, 80% will just, you know, clear the virus and never mount a bad immune response. So as a surgeon, you're going to be evaluating your patients, and again, the things to look for or ask about are dry cough, fever, protracted fever where you go to a GP multiple times has been shown to be a risk factor, shortness of breath, but it could be very subtle like loss of taste or loss of smell, and that may be your easiest question to ask, as well as exposures. In terms of physical exam, again, look for the fever. It can be mild, 37.5 and above, but it can also just be sort of sustained at 38. Listen for crackles and wheezing, but mainly crackles. And then look at the labs. Look for lymphopenia, leukopenia, which is not uncommon, but that along with a raised CRP in the right setting can make you worry about it. The infiltrates are often peripheral. And as you may have heard in China, especially before there was good testing, CT scan showed the early changes even before a chest x-ray, and it's often very peripheral looking. signs. So one of the things that people want to know about is the swab and how good is the swab. So early on, the sensitivity of a swab, if you do it well, which is a good nasopharyngeal swab, maybe also sweeping the anterior or the mid-nasal cavity, is highly sensitive. But we generally recommend doing 2 over 24 hours to really rule it out if you catch people in that early stage. What I want to point out is by the time patients have pneumonia, the sensitivity of the swab really drops to 72%, because at that point, the virus is in the lower respiratory tract. So if you can get sputum or ET fluid, that's much better, but you may not be able to diagnose the pneumonia with just a swab. This is the MOH criteria to show what PPE is considered protective. And the only things I want to point out is for aerosol generating procedures, definitely wearing an N95 with gown, gloves, and eye protection is necessary. And for casual contact, so if you were exposed to a patient for less than 30 minutes, face-to-face, but casual contact, and you were wearing your surgical mask and did hand hygiene, then you're safe. There's no follow-up required. And that's worked for us. We've actually stratified our exposures or breaches that way. And so far, our breaches have not had infection. So in conclusion, COVID-19 has many manifestations. It's kind of weird. It makes sense, right? It's a coronavirus, and coronaviruses cause the common cold. So you see that spectrum, but SARS was also a coronavirus, and there's an 80% similarity between the two virus DNA. So you see the SARS spectrum as well. So it's a huge spectrum. And when people go on to get the SARS, it's usually after day 9 or around day 7 to day 9. So when you talk to your patients, take a very targeted history, look for the signs and symptoms we talked about, look at the labs, especially the lymphopenia, CRP, with a normal procal, and remember your PPE, and that it's mainly spread by droplets and fomites, and that normal hand washing, 70% alcohol, and then the normal hospital grade cleaners will disinfect it. And then the swab technique matters. Thank you. That's my last slide.
Thank you very much for that great talk. Are there any questions? We'll take 2 questions from the audience. For Jyoti, please, if you could identify yourself. Any questions on the floor? I think there's in the chat room.
Hi, Jyoti. It is Brian here.
Hi, Brian.
Hi. I was just wondering, is there any concern about blood transfusions? As in, because in the slide you showed about Chinese patients, there were some that had a temporary, short-lived viremia.
Sure.
So should we, is the blood bank screening for COVID?
Host unmuted all, but
I know right now they're not.
look at the mix.
I don't actually know if they are yet. I think we have a lot of unknowns, and those numbers so far, we don't even know the stage of those patients who were positive. We know that in China, those early studies, you can imagine. Very sick.
Thanks, Jyoti.
Yes. So,
all right, I think, thank you very much.
I would just want to say one more thing for Brian's question, which is a good one. So there's 2 things that the virus needs to get into you. One is exposed to you, but the other is to attach to the receptors. As you all know, the ACE inhibitor receptor, the ACE2 is the receptor that it enters. So I guess the other question would be, even if you were exposed from a viremia, would you get infected? So I do think that there'll be more papers coming out looking at that route of infection and whether it's even a possibility.
Thank you, Jyoti. Thank you for the great talk. And for all those people who could not join this seminar for any reason, this would go on to the YouTube. We will record it and put it on the ELSA webpage. We have an overwhelming response and systems are kind of crashing everywhere. We'll do that in times. It's a great honor to invite our next speaker. Jyoti, if you would want to take your slide down, and we could move on with Raj.
Oh yeah, how do I do that? Let's see.
You just cancel your PowerPoint and it will be okay.
Oh, okay.
Okay. Okay, I took the rights away from you and I'll give it back to somebody else now.
Okay.
All right, so it's a great pleasure for me to introduce our next speaker, Dr. Raj Menon. Raj is, he's a humble guy. He's just a trauma surgeon in UH, but he mans the entire Department of Surgery's manpower. He's been actively involved in the response to COVID. He's currently the clinical director. So I would pass over to Raj, and Raj is going to speak to us about a ready operating room. Raj, over to you.
Hi, good morning, everyone. Hi, good morning, everyone. I'm Raj. I'm a trauma and vascular surgeon from NUH, as Professor has mentioned, and I'll just share with you a little bit, just about a 5-minute tour, in a sense, of what our COVID-19 ready operating room looks like. These are rooms that we use specifically for patients who are COVID suspects or COVID positives. And increasingly, we are seeing greater and greater use of these rooms. And I thought it will be good to just give you a pictorial diagram of exactly how this works in a tertiary hospital in Singapore. So we'll run through some of the principles of running a COVID-19 OT. Later, my colleagues will be giving a discussion on the anesthetic components and specific surgical points, which I won't be covering in this, but this is more of an infrastructural setup that we're going to be discussing. We'll also be going through some key learning points that we have encountered from our initial experience in using such a theatre. Now, I think the key principle in organizing this within your own hospitals, if it's not already set up, is essentially a focus on staff safety. Protocols will need to be rewritten because this is a very new disease that we are tackling. We may have had previous precautions for infectious disease cases, but some of those may have been not used for a while, and sometimes we need to review and redevelop some of these protocols, including the screening, the transport, transfer, intraoperative and post-operative management protocols. Along with this is also, of course, the decision-making for surgery. Do we really need surgery? Do we need general anesthesia? And reducing the impact of procedures which require aerosolization, which has a greater risk to staff safety. We can't emphasize the need for PPE and training more, and just having PPE itself is only one half of the equation. You do need to ensure that everyone is trained to use it, and many people would have completed their PPE training long ago and may have forgotten or may have been a bit rusty in its use. And we found that there was a big gap in the number of people who needed retraining during this period of time. And lastly, of course, the importance of drills and rehearsals in managing and to make sure it's a safe environment for everyone. In my hospital, what we have is we are privileged to have a negative pressure theatre. So this is a theatre which was built in right from the beginning, and this actually allows us to operate on infected cases without contamination of the rest of the OT facility. For institutes without this, this kind of a theatre, additional precautions will need to be taken in terms of keep having an operating room in a far corner of your operating complex as far as possible, and with an ingress and egress pathways which are different from the majority of patients. In a sense, patients should enter this theatre through a particular pathway and leave through a particular pathway to minimize contact with others. So as you can see from this diagram here, the picture on the left is essentially the pathway entering this theatre, and it's segregated, as you can see from the overall map on the right. That is quite segregated from everywhere else, so in order to minimize contact. So if you have a negative pressure theatre, good. If you don't, at the very least, try to create a theatre at the corner of your complex, away from everyone when you're operating on COVID suspect or positive cases. The area outside is dedicated to our personal protective equipment, and most of the donning and doffing of our PPE is done in this area, including the use of PAPRs. PAPRs especially are used for aerosol generating procedures, and our anesthetists use them for intubation as well. Other surgical procedures like tracheostomies, all this, we do as a principle, we do encourage the use of PAPR. However, as a minimum, we require everyone to be wearing a full gown and 95 masks and goggles during this procedure. This is the area outside the theater for people to start wearing this before entering the operating theater. We ensure that there's good labeling and that everything is quite easily identifiable, so that new people who are coming to the theater for the first time will be very clear on where to put their various items. Now, every negative pressure theater has an NT room, and an NT room is basically a room which is kept separate from the main operating theater at all times. In this room, most of our scrub staff are preparing the equipment. All the temporary equipment is kept here, and you can see that in this room there's a second door before it enters the main operating theater, and this door will not open until the door of the antechamber to the external environment is closed. So in that sense, making sure that there's no continuous communication from inside the theater to the external. So these are doors which are electronically configured, that if one door opens, the other door must remain closed, and in that way it prevents things from going. In hospitals which don't have this computerized facility, then manually we have to make that adjustment to make sure that there's no constant communication between the internal operating theater environment and the rest of the theater complex. So that's one area to look at for. And this is where scrub nurses who are preparing the equipment and who are on the way to removing equipment, bring the equipment to, and waiting for the internal door to close before it can be redistributed out. Signages are everywhere to make sure that people are clear on what the protocols are. We don't get people running in of the theater straight out. For every single case, we have a runner who is there to basically help you run from theater to theater to get the various items that you need. But every time you do that, there's going to be a delay as you wait for the various doors to open and close and for the pressurization to normalize. Clear labeling and signages are important everywhere so that people are constantly reminded on how to do it. I wanted to make an emphasis on the importance of security and environmental services in these kind of handling of these patients. So we use the security staff to clear the way as a patient's arriving, to minimize contact with the public and other patients. We have environmental services who basically help to clean up the lifts, to wipe things down whenever the patient has used it, to minimize the impact on the other patients and visitors to the hospital. And these are some of the simple safety measures you can take as in a hospital to try to maximize patient and staff safety. Now, this is a picture of a normal OR in my hospital and how it's usually set up for non-infective cases. You can see it's full of equipment. This is the scrub preparation room on the right. You can see it's full of drawers and equipment and things for you to utilize for surgery so that things are very quickly available. However, in our COVID theaters, it's not so. Everything is emptied out. We remove every piece of non-essential equipment out of it, and we only bring in equipment that we need. And we do this in order to minimize contamination of equipment and to reduce the cleaning burden, because cleaning the theater at the end of surgery is a huge task. And if you reduce the number of items within it, you'll be able to turn over the theater much faster. So this is an important component, and it means you need a lot of planning because you're not going to have all your equipment ready to go when you start surgery, and you need to get everything pre-prepared. So you only bring in what's essential before you start surgery. Now, and just to reiterate the point, keep the theaters as empty as possible. Just bring in what you need prior. And it's important for everyone to meet up and huddle prior to surgery so that you know how to prepare and predict for not only what you expect to need, but also to a certain amount of contingency planning so that you have extra equipment in case you require more than what you initially imagined. There are a few issues for surgical staff as well, which is a bit of a change from peacetime. One, we try to minimize the surgical team. We try to make it as small as possible using senior members to reduce the exposure to staff, especially to the juniors. Having a senior staff also may correlate to a faster operation, fewer complications, and minimizes time of exposure to all healthcare workers. Do note that if a senior staff member does get COVID at the older age, especially more than 60, there is an implication there as well. So you got to balance this out. But in essence, get a team who is capable of the job. There's not a training opportunity, and as few people as possible in theatre. Make sure your pre-training is done as mentioned so that everyone is ready to go. And on top of that, if I may add, we try to use a buddy system so that each surgeon cross-checks his PPE before going in to make sure that they are properly gowned up and there are no gaps anywhere. And having this kind of a partner checking you helps. It does slow things down, but it's very important in these kind of situations to be able to clearly show to each other that you are properly attired. This is a bit more specific to our unit, where we actually try to keep the surgeons out during intubation and extubation to reduce the number of people within the main operating theatre during the time of maximal aerosolization. And we try to keep them out for about 10 minutes or so during intubation and extubation. This is not always possible depending on your own hospital configuration, but that's something that we try to do over here. We try to leave our own personal material out of the theatre as well. And the key thing would be your handphones and cellular phones. So we leave them with external team members. For those on call, we get someone else to field all the calls while the team operating on the COVID patient is operating. Some of the difficulties we have faced in these by doing this is that certainly when you're allocating time for surgery, you need a longer setup and stand down time, so don't overbook your cases into a list. Project your equipment needs well in advance, but don't oversupply either, because when you oversupply, you may need to clean quite a bit as well. And always have a set of runners who can you can communicate with, and so that they can run to get equipment rather than OT staff leaving the theatre physically and going to get equipment. In that sense, you minimize this cross-transference of droplets external to the theatre. So to summarize this very brief introduction and workflow drills for the operating theatre, have a clear ingress and egress plan from the operating theatre, rehearse this with all staff, including security, environmental services, have a huddle with your anesthetists, surgeons, scrubs, and circulating nurses. One of my colleagues later will be talking about how do you do CPR and code blue drills for operative patients. And lastly, this is an operational concern. There's not a teaching moment. So use trained and effective staff for these kind of procedures as well. And I think that's my last slide. I'll be happy to take any questions from either the chat or anyone live as well.
Well, thank you, Raj. Thank you, Raj, for that. And if there are any questions for Raj, please type them on the chat. And while the next speaker is talking, he will answer the questions on the chat box, please. So, Raj, you want to take off your screen, please? Okay, so it's a great honor to invite the next speaker. The next speaker we have is Razali. Razali Mahdi. Razali is basically a senior nurse clinician at the National University Hospital with the infection prevention unit here, and he will be speaking to us about PPE and PAPR used for healthcare workers when caring for COVID-19. A subsection of this will be presented by Mahir in his last talk. So Razali, over to you. I'm going to mute myself and then you can take over from me. All right, just a minute. Just 1 minute. Let me, sorry, this is a little bit of a cumbersome work. All right.
Okay. Thanks, Dr. Asim. Can you hear me?
Yes, we can hear you.
Okay.
So, Razali, please head on.
All right, great. Thanks to Dr. Asim and the organization team for inviting me over. So I'm going to share about PPE use in our hospital. But as the infection prevention team, we actually work very closely with different departments in the hospital like in the operating theater, EMD, isolation ward and general wards, to look at their infection control practices, setup, and also processes that's involved in that. So as we all know, PPE is actually designed to protect the healthcare worker against harmful patient pathogen. It creates a kind of a protective barrier for us. And understanding how transmission occurs for COVID-19 is important so that we can actually break the chain of infection by putting on the necessary and correct PPE. Next, please. Right, early on when COVID-19 came to our shores, there was a guidance from our Ministry of Health on the PPE recommendations to be used. Sorry, one back. So one slide back, please, thank you. Yes, so the Ministry of Health have recommended a set of minimum PPE to be used during the care of the suspect or confirmed cases. And this is used during the transfer management, during diagnostic procedures, treatment, etc. And in our hospital, there are also guidelines available on what PPE to wear where you work, whether it's at the low risk or high risk area. The next slide, I will go through with you the specific PPE items that are to be used. All right, the first one is actually the N95 mask, like what Dr. Raj have mentioned earlier. This is quite crucial because sometimes staff may not be wearing N95 most of the time if they're not working in isolation wards per se, and they may either lose or gain weight or even have some facial surgery which may affect their mask wearing to have a proper seal. So we'll advise staff who have not been wearing N95 in their daily work to actually go for a proper mask fit so that they have a very good seal. The next one is the face shield or goggles. This is primarily to prevent splashes, exposures to the eyes and face. And from what I understand in the OT setting, surgeons will usually like to wear both together if there are potential major splashes, to wear both the face shield and the goggles together. Next one is the long sleeve gowns. These are level 4 gowns in accordance to AMI standards, which can be used up to an hour or so and provides fluid resistance properties as well. And next is the latex glove. Generally in the EMD or isolation ward setting, we did not wear sterile gloves, but in OT setting, definitely wear your sterile gloves. I understand some surgeons will actually prefer to wear double gloves as well. All right. The other important factor, which I now put inside my slide, is actually to wear a covered shoe, right? And if you don't have that, some would in fact put in a shoe cover or even a boot covers. So next. Next, I will need the help of Dr. Asim to play this video. This is actually the video of a sequence of the donning of the PPE with the minimum PPE requirements. All right, since there's no volume, I'll just give a bit of commentary. So before putting on your PPE, the key important thing is to perform your hand hygiene in NUH. some areas may use 7 steps or even 8 steps of hand hygiene. That's fine as well. Following your hand hygiene, we always emphasize to put on whatever is actually on the top of your face. So that's the N95 mask. And when you wear your N95 mask, key thing is to ensure that you shape your mask properly. At the top, there's actually a metal sheet where you should shape your mask, perform user self-seal check, and check whether there's any air escaping or not. If yes, then you need to adjust your mask. And make sure it's actually at the crown of your head. Next, wear your or your goggles. Make sure it fits nicely. And rest of the intubation. So while putting on your long sleeve gown, ensure that you do not tie a dead knot. I mean, that's crucial because you don't want to be able to, you don't want to snap off the PPE later on, which may cause some aerosolization. So it's important to tie a ribbon knot and secure it, overlap, yeah, and for easy removal as well if you tie a ribbon knot. So following your donning of your gowns, we will emphasize to perform hand hygiene again before you put on your gloves. Okay, we can.
Just a minute, guys.
Right, so with PPE donning, the key messages that we are trying to say across is actually, first thing is the N95 mask, because in our hospital, true, we do have staff who actually thought they can wear the existing mask, which was fitted for them many years ago. And when they come to the clinical area, I mean, there have been some gaps and they are not able to have a good seal. So ensure that crucially staff goes for their mask fitting again. A poster is always good as a reference point at prominent donning locations as a guide. But however, this does not replace the fact that staff must go through proper PPE, donning and doffing and be certified competent. It will also be good if hospitals can also provide spotters, which means that staff who are there to just make sure that staff are actually putting on their PPE properly during the donning and doffing process. And finally, check integrity of the PPE. We can't be too sure that all our PPE come a good condition. There may be integrity issues. They could be torn. There's no string and things like that. So you don't want to compromise yourself. So ensure integrity of PPE even before putting it on. Next, we'll go to the removal video, PPE removal video. Thank you, Dr. Hassim. Yep. For PPE removal, always remember to remove what is the most dirtiest, which is the gloves. Yeah, because you'll be touching patients and the environment. So remove your gloves. Remember, do not touch the outside of the gown. It's contaminated. Everything which is on the front part of your gown is contaminated. Pinch one side of the glove and pull out gloves gently. And secondly, with the ungloved hands, slide fingers underneath the gloves and pull it out gently. Yeah, the key message here is do not rush. Thereafter, perform hand hygiene. If you notice, there's a lot of hand hygiene moments here. Basically, you clean your hands after every removal of the PPE. So following that, remember I was sharing with you about removing of the gown. So you don't snap it, gently remove the string from top to bottom or bottom to top, that's fine. And untie it gently. And remember, do not touch the outer layer of the gown, that's contaminated. But however, you can touch the inside. So as you can see in the video, my colleague here is removing it slowly and touching the inside portion of the gown away from her. Yes, this video is intentionally slow motion so you can see the movement. Remove one side of the gown and then see she's touching only the inside portion of it away from you. And remember to fold it inside out. And after this is hand hygiene. And as earlier mentioned by Dr. Raj, if you are working in the operating theater with negative pressure room, it's always recommended not to remove your N95 mask within the operating theater. So next step is removal of the face shield, followed by hand hygiene, step out of the operating theater, and you remove your N95 mask. And there's a technique to removing of the N95 mask, which will be shown in the video. And obviously, first remove the bottom strap and do not touch the front of the mask that's contaminated. Hold on to the strap and using the other hand, remove the top strap of the mask away from you and discard it immediately. All right. At this point of time, healthcare workers need to know that they cannot touch their face. You know, sometimes the hair is all flying and all that. Don't touch your face. Perform hand hygiene. You may be contaminating yourself. Okay, we go to the slide next, Dr. Asim. So with the removal of PPE, key message, do not rush. Yeah, we go one slide behind. Key message is do not rush. Always take your time. You're not rushing to anywhere. Yep. And obviously, we do not want healthcare workers or staff to contaminate themselves. So do not rush during doffing of PPE. Like what I mentioned earlier, where possible, encourage our spotter to be available. Sometimes when staff are in the theater for a very long time, you know, they're just tired, they just want to take everything off, you know, without thinking they may be contaminating themselves. So it's good to have a spotter to instruct them step by step. Hey, first remove your gloves, hand hygiene, remove your gown, hand hygiene. You're in good shape, you know, take your time. Always encourage people, yeah. And the other key message is to perform hand hygiene at every step of PPE removal. Even though people may say, hey, you know, there's too much hand hygiene, my hands are sticky and dry, but we don't want to take the risk, yeah. So we have to enforce this. Next slide, please. Right. So I think some of the speakers have already talked about PAPRs, and even though N95 masks, full PP are good enough, aerosol generating procedures, some would like to actually wear the PAPR if they are doing intubation, bronchoscopy, mechanical ventilation, etc. It is possible to wear those.
I think we will skip the videos in the interest of time. They would be up on the website, and you can see them there. Razali, if you just want to go through these, it's okay, but we'll skip the video.
Sure. There's no video for PAPR, no worries. So these are the posters that we will put across the hospital wherever the potential use of PAPRs may be in the ICU or in the operating theater. Yeah, so we can go next. Yeah, if you need more information, you can just click on these are the two types of PAPR that we use in the hospital. And that's about it for me. Thank you.
Well, thank you very much for that interesting talk, Razali. And then I would, if there are any questions for Razali, please type in the chat box. While Brian gives his talk, Razali can answer those talks for you. Brian, are you available? And are you okay to share your screen?
Yes, I'm here.
Thank you, Brian. Please proceed. I would mute myself. Share your screen.
Can you hear and see me?
Brian, we can hear and see you.
Okay. Hi.
Do you want to share your screen?
I have shared my screen. Can you see it? No?
No, Brian, we can't.
Okay, hold on.
Just a minute, Brian. Let me just make sure. Yeah, there are multiple participants. All right, Brian. I can't
share my screen.
I can see you.
Okay.
Okay, Brian.
Okay. Now.
Okay, now we've got it. You can do a PowerPoint to it.
Yeah.
Yeah.
Okay. Hi. Good afternoon, everyone. Why is this not starting? Okay. Good afternoon. I have not much disclosures, except that to let everyone know that I don't intend to reopen the American economy next week. And all I have learned, all I'm sharing today, I learned over the past 3 months or so. So right now we are maybe about going to the 4th month into this COVID situation. And to me, I think we've actually more questions than we have got solid answers. And the questions I would have is that, you know, there are zombies in our midst, and we just cannot identify who these zombies are. You know, we know that there's asymptomatic spread, pre-symptomatic spread. Swabs may be false positive. People who have been infected, recovered, and reinfected and start shedding the virus once more. So there's lots of stuff which we don't know about this virus, yes, about how it transmits, and even why some of us seem to get it much worse compared to the rest. So, and this is just one patient whom I encountered, which really drives home the point to me. He was swabbed like once every day for about over the course of 2 weeks, and the swabs will occasionally be positive. So that to me is a very, very worrying sign. But as what Jyoti said previously, as the disease progresses and the virus from the nose and the pharynx goes down deeper to the lungs and the bronchi, then it gets harder to get a positive swab without there being a really good sample. But we can't intubate everyone to get a good sample. So what it tells me is we really need to have very good protocols in place for us to detect these zombies, because we are not afraid of the known zombies. It's the silent zombies which should scare us all. All right, and the next thing that everyone is fearful about is it airborne? Is it not airborne? And I think it is almost certainly for now not airborne, because if it was airborne, many more of us would be infected. And I am sure we've all been to this. We all go to this website like once every day and freak out when the numbers have jumped once again. And even then, the R naught for the coronavirus is less than 5. So I think it's not airborne. So it's mainly droplet. So if it's droplets, like what was said previously, we just need to wear a mask and we need to have hand hygiene and wear PPEs that will protect our exposed mucous membranes. And we need to maintain a fairly safe distance. If it was airborne, then we swap the surgical mask for the N95 mask, and we try and keep them in the rooms which are negative pressure. The overlap comes during the aerosolizing procedures that we talked about. And this is a list from the UK, and they've actually quantified it such that and ranked it such that the most aerosolizing procedures are tracheal intubation, non-invasive ventilation, all the CPAPs, PAPRs that we do in the ward. We may want to think twice now. Like in the past, we used to say, oh, this patient seems to be deteriorating. Let's see if we can stave off intubating and positive pressure ventilation for a few days. But now it seems like that may not be a wise decision, because that may aerosolize his viral particles, and staff and patients around him may be put at risk. This is another view of airborne and droplet spread. So when talking and breathing and sneezing and intubating, we produce particles. Most of them would be greater than 10 micrometers, which would be less of a problem to us. But if it's less than 5 to 10 micrometers, then it becomes a problem, as it's able to penetrate deep into the deep into our bronchi and the respiratory system. So assuming we are doing an aerosolizing procedure, we talked about PPEs, and at the same time we are also we can also institute some engineering control measures. So Raj talked about the negative pressure, and this is a close schematic diagram of the negative pressure room which Raj talked about. And if you see here, so although we say the room is negative pressure, the operating complex itself, the MBOT 15, where the surgery is conducted, is actually still at a positive pressure. So this ensures that, you know, there's no risk of wound infection to that individual patient. But what is negative pressure is the rooms that are actually adjacent to the corridor. So the induction room and the antechamber are negative pressure, which means that when the door opens, when the OT door opens, air from the OT will rush into the antechamber. And when the corridor door opens, air from the corridor will rush into the antechamber and it will keep the contaminated air in. This knowing your airflow and where your negative pressure is very, very important, especially when it comes to the donning and doffing. So I will go into that in a great more detail. But suffice to say, for us, we will remove our PPEs, the yellow gowns that you saw. We will remove them in the antechamber, but we will keep the PAPR on. We'll keep the yellow gown. Sorry, we'll remove the yellow gown in the antechamber. Keep our PAPR and N95 on, and only after we go out to the corridor do we take off our PAPR. Then one word about air exchanges. In our OT, we have the air exchange about 20 times every 60 minutes. That means one full air exchange every 3 minutes. So one full air exchange will reduce the viral load in the air by about 63%. So by about 5 air exchanges, the concentration of viral particles in the air would actually be less than 1%, which means that if you have staff which are not protected, they should not be anywhere near the intubation and the reversal. And where possible, if there is luxury of time, the staff should actually enter after 15 minutes after the air is secured for maximal safety. Although the staff entering the our OT complex would already be wearing the N95 mask anyway, so most of the time it's all pretty safe. So so we are now talking about zombies and how do we ensure that we do not select a zombie for surgery. So we have had a case whereby in a neighboring hospital, a patient was had a lab chole done. 3 days later, came down with a fever, and then was later on diagnosed to have COVID. And at that point in time, the staff in the theater, some had N95s on, some had surgical masks on, and because of that, quite a few people in that surgical team had to be quarantined for 2 weeks. So we don't want such a situation to happen, because in these situations, healthcare workers are the assets which you really need to protect, because with us working, we are a force multiplier. When we fall ill, not only can we not help, but we are adding to the weight of the problem. So for us, for any suspect or confirmed case, we would, if we start from the top square, so any suspect or confirmed case, if it's yes, we ask ourselves, can the surgery be delayed for 2 weeks? If the surgery can be delayed for 2 weeks, well and good, let's postpone him. In the non-COVID recent past, like let's say 4 months ago, we actually would have proceeded with cancer surgery, because the concern then was, if we postpone him now, will he have an operating slot in 2 weeks' time? So therefore, in the past, even when the patient had a slight flu, we would actually have proceeded. But now things have changed slightly, as in workload has come down quite a fair bit. So we now have no problems finding an operating slot 2 weeks from now. So our preference is to postpone surgery till after the patient recovers fully. So if the surgery can't be delayed, or if the patient has got some acute respiratory infection, or if the patient has had some close contact with a suspect or confirmed case and the surgery cannot be postponed, then we will perform the surgery in that COVID theater which we talked about previously. So other than the N95 mask and goggles, we also don the PAPR during induction and at reversal. Our stocks of PAPR are fairly limited. So each theater only has 4 PAPRs. So at that point in time, anyone within 2 meters of the patient will have a PAPR on, and anyone who has no business being in the theater is asked to leave until they are told that the coast is clear. And moving on to the green column, so all other seemingly healthy, happy human beings, we will treat them as possible zombies and still proceed with surgery, induction with N95 and some form of eye protection. So we have talked about this full PPE, eye protection, N95, long sleeve yellow gown, gloves, and as well as shoe covers. Just a short word about PAPRs. We talked about it a lot. There's a worldwide shortage. We have very heated discussions about buying of PAPRs, deployment of PAPRs within the hospital. But actually, there is not much scientific evidence about PAPRs and how protective they can be. Of course, in the same vein, there is not much scientific evidence to support the use of parachutes, but most of us would want one when we decide to jump off a plane. What I could find was that if you have a PAPR, this additional hood that you have forms another layer, preventing droplet contamination of your gown beneath this hood, and this may prevent infections. But donning a PAPR does come with at a cost. Firstly, with the whir of the blower, it makes communication quite difficult. And if you look at some of these hoods, they are full bodied hoods. So for us, there was a question in the chat just now about when we are in Theatre 15, how do we communicate with the people on the outside for us to get our equipment? So our OT runner has got a phone, and using the landline from inside the theater, we do call out to request for drugs and equipment. But with these, you would be holding a phone to the external surface of his ear. So there'll be one layer, and you add to that this blowing sound, like from the top, like a soft hair dryer. So it does make communication quite difficult. And if we are using it for a ward round, I don't think you'll be able to hear the crackles very, very clearly. And of course, in a code blue situation, there will be donning and doffing delays. We timed it, and the average time added on putting on a PAPR is about 3 to 4 minutes. So in a code blue situation where someone is already doing CPR, and if you can see that patient clearly needs to be shocked, perhaps some would consider entering with the room without a PAPR, although I personally would think that if it was me, I would want to protect myself and my staff, because if one of my staff is down, if the whole ward of ICU nurses, whole shift of ICU nurses gets quarantined because of one heroic act, then it may not be worth the cost. So having said so much about the PAPR not being proven to be useful, why do we cling so tightly to it? And I think it's because we first started using the PAPR during SARS, and we found that actually those who use the PAPR didn't come down with SARS, and so I think if something worked for you, we tend to cling on to it. And COVID-19 infection, to me, it seems a bit more infectious than SARS because of these silent zombies, you know. So you don't know who's going to be ill. So you don't know whether, without using the PAPR, have you been indirectly infected? And for the next 2 weeks, you may be going around infecting your whole department. Moving on to the general OT setup, as Raj said, we tend to minimize everything, which means it's minimizing everything and maximizing frustration to the staff in the OT. So as a surgeon, if you're going to do a bowel anastomosis, we will not bring in the stapler that you want until you're very sure that that's the stapler that you want. And when it's brought in and you realize, oh no, I need another stapler or I need another Hemalock or something else, then unfortunately, we need to call the runner to bring it in. So everything in the in this theater takes longer to happen. The patients will be brought to the OT directly, not passing through reception. And once surgery is done, they will be brought out. Sorry, they'll be recovered in the OT itself and discharged directly back to the ward without passing through PACU. And once the patient leaves, then we would clean the OT thoroughly. There was a question about what do we use in our hospital. So we use these. I'm not exactly sure why one is used for one surface and not the other surface, but I'm sure they will all be virucidal, but just that some may spoil your screens. So just one slide about what to do regarding anesthesia for COVID. So we would generally avoid high flows. So even in the ward, if you have any patient who is deteriorating, even in the ED, usually principles of resuscitation, high flow, 100% O2. In this case, I would run sufficient O2 to keep the sets about 97 to 100%. Because bearing in mind, if the flows are high, if at that point in time the patient should cough, then that high flow O2 acts to as an aerosolizing agent to push these viral particles further from the patient. We try to avoid circuit disconnections as far as possible. If we know the patient is going to the ICU post-op, we will request for the ICU ventilator to be brought in, and then we will use the ICU ventilator and transport the patient back to the ICU with the same ventilator. If we do have to disconnect the endotracheal tube, we will clamp the ETT before we disconnect. Like what Raj says, COVID time or the COVID patient is not the time to learn. So the most experienced person will take the airway, choosing a plan which will work. Okay, our plan A is a plan which will work to secure the airway at first pass. And once the airway is secured, assuming there is minimal leak to the system, then actually risk to the surrounding staff is minimal. And then at that point in time, other staff can come in without any PAPR. And again, at the end of surgery, we do the reverse. We chase all the staff out, put on the PAPRs once more, and we extubate the patient. As soon as possible, we put on a surgical mask for this patient, and then we discharge patient after about half an hour if the patient is stable. I think this is my last slide. So, so what I said just now about donning and doffing protocols. So we have a room that is designated negative pressure. That's our go-to COVID theater. But we have actually designated another theater as the standby theater, just in case there's a rush-in Caesar which cannot wait. So that is actually our theater 16. All other theaters in our theater complex are positive pressure theaters. So we have actually designated theater 16 as a negative pressure room, which means the OT complex itself, it's all the rooms in the OT complex, the pressure is equalized to the corridor pressure. So when doors open, no air moves in or out. So in such a scenario, we actually have chosen to don our PPE at the Blue Star before we enter the surgical complex, and we will doff our PPE in the induction room. Okay, that's all I have. I will be happy to take questions.
Thank you, Brian. I think we'll keep the questions offline. Brian, what you will get the questions in the chat box. I see Maki Falona has already posted a question for you. So
Okay.
if you take the questions offline, that would be great.
Okay, sure.
If you could stop sharing your screen, and I would get our next speaker, Dr. Matthew Cove. Matthew is a senior consultant. He is an intensivist with the University Medical Center, and he's going to give us something about ventilation in COVID-positive patients.
Okay.
Thank you. Matthew, are you there?
Yes, I am. Can you hear me?
Yes, we can hear you. Please, can you share your screen, Matthew?
Yeah, I am in the process of doing that. Can you let me know when it comes up?
I can see your screen. You just need to go to PowerPoint mode.
Okay. Is it in PowerPoint mode now?
It is.
Okay, great. Well, thanks for the invitation, Asim, and for the introduction. I think just before I jump into this talk, I should mention a couple of disclosures, mainly some grant support and consulting fees from both Baxter and Medtronic are probably the most pertinent to this talk. So I was asked to talk about sort of ventilation issues with COVID-19 positive surgical patients. And I saw Brian was talking about the anesthesia issues before this. So I decided to focus on more, how do we approach a COVID-19 post-op surgical patient? So we've operated on the patient and they've developed essentially a post-op pneumonia from COVID-19, because that's how this is going to present. And when we're really talking about COVID-19, we're talking in the hospitalized patients, we're talking about managing a difficult pneumonia. So Jyoti already covered some of this, and really for most of the patients, the good news is about 80% are probably not going to give us too much trouble. They're only going to experience a mild or moderate pneumonia. So that means this is data from the WHO trip to China. And what they noticed was about, of this 80%, about half didn't really even have chest x-ray changes, just a very, very mild pneumonia. And I think the ones we're worried about, and the ones where we see the complications and the death, are really the remaining 15 to 20%. And these are the patients that become hypoxic, they need a lot more support, and potentially go on to get critically ill and end up in the ICU on a ventilator. So I just thought I'd focus on the issues that are particularly different about these patients in our experience over the last 3 months. So any pneumonia, I mean, obviously the main thing we worry about is the hypoxia. And for COVID-19 patients, it's no different, except the hypoxia tends to be worse in those severe patients. The way we approach hypoxia in a COVID-19 patient is really no different. You start with supplemental oxygen, and if that's not enough, you escalate your care. And what I thought I'd focus on is when we get into the range of ventilatory support and the issues related to these. So I think any intensivist, when we first started hearing about what we now call COVID-19 and the situation in Wuhan, the first things we were all worrying about, and the things we were all talking about, is normally when we have a patient with pneumonia who ends up in the ICU or ends up approaching the ICU, a lot of the time in the last 10 or 15 years, we manage these with high flow oxygen therapy, high flow nasal cannula, or some centers NIV. But of course, these interventions, you can imagine, particularly with high flow oxygen, but also NIV. NIV, you get a lot of leak from the mask. With high flow oxygen, you're delivering anywhere from 21 to 100% oxygen through the nose at a flow rate of 60 liters per minute. And we're talking about a highly infectious respiratory tract infection. The question everybody has is, do these interventions increase the risk of nosocomial spread? To help us with this, there's been essentially two guidelines released in the last 3 months. The WHO provided some clinical management guidelines, and also the Surviving Sepsis campaign provides some guidelines. And what they tell us is we should probably be choosing high flow oxygen therapy or high flow nasal cannula over NIV in these patients if they've got hypoxemic respiratory failure. And both guidelines initially said that the risk of environmental contamination with these interventions was no higher or similar to the risks with conventional oxygen therapy. And I just thought I'd spend a few minutes unpacking these two statements. So first of all, why do we recommend high flow oxygen therapy over NIV in these patients? And this is now a recommendation that's pretty ingrained in intensive care practice. And for the last 5 years, we've based these recommendations predominantly on this study it was a French study. They randomized over 300 patients into NIV, standard oxygen, or high flow. Now, these were patients with hypoxemic respiratory failure, but the majority, well over 80%, actually had pneumonia. And you can see from their survival curves that the clear winner is high flow oxygen therapy. And of course, related to this, the patients that were more hypoxic, the PF ratio less than 200, high flow oxygen therapy compared to the other two interventions seemed to keep people off the ventilators, which again is a desirable outcome with any hypoxemic respiratory failure or pneumonia. So why is NIV less effective compared to high flow oxygen therapy, or why is it associated with an increased mortality? Well, it seems to be because for whatever reason, we end up delaying intubation when patients are on NIV. So we know from the NIV data is if we're treating any pneumonia patient, viral or bacterial, with NIV, if you keep them off the ventilator, it's great. They have a very low mortality. In fact, most studies close to 0. But the problem is if these patients end up going on to need intubation after being on NIV, we're seeing mortality rates in the range of 50%. And this is a lot higher than the conventional mortality we see for intubated pneumonia patients, which is closer to 20%. And this next slide probably shows us why that is. And what we see is that the patients that die on NIV, they're getting intubated later. And we think this delay in intubation is what's contributing to the mortality. For some reason, we don't see that with high flow oxygen therapy. And I don't know why that is. It might just be that because we're getting a little bit more ventilatory support with NIV, we're feeling overly reassured and leaving it on longer. And then I just wanted to unpack this statement too. To say that high flow oxygen therapy has similar environmental contamination rate to conventional oxygen. They also said similar statements about NIV in both guidelines. And they're basing this on 3 studies. And I've just shown one of the studies here. The studies were based in essentially simulation patients. And the WHO were actually challenged from multiple angles on their statement in January, and have since revised their statement and have removed their statement about high flow oxygen therapy being as safe as conventional oxygen. And I think it was appropriate to do that. And the reason for that is because the data they were basing their recommendations on, and it's the same for the Surviving Sepsis campaign, were these lab-based studies in patient simulators. So these aren't real patients. And what they're essentially showing is that with high flow oxygen therapy, if your cannulas fit well and your patient has lung injury, you don't get a lot of aerosolization of the respiratory tract secretions. A bit more with normal lungs because they have a higher tidal volume. But the problems with this is a simulation. So the patient's not moving, the patient's not coughing. And in my experience, patients with pneumonia, they're moving around the room, they're coughing, and the nasal cannula are always slipping out. It's not a tight, snug fit. So to extrapolate this to the clinical situation is risky. And on top of that, we have some of the data, I think Jyoti showed some of this work. We can detect viral RNA in the air room of our patients. And not only that, and this, I think Jyoti also showed this, this is just comparing aerosolization and virus survival with the SARS virus and now our COVID-19 virus. You can see that the virus does survive aerosolization. So we have to be extremely careful with any interventions that cause aerosolization. And so I think it was appropriate that WHO revised their recommendations, and the Surviving Sepsis campaign haven't yet, but there's talk that they may. So really, when we approach these pneumonia patients, we can use NIV or high flow oxygen therapy. The recommendation is no different to any other pneumonia. We should be using high flow over NIV, but you've got to use it with the airborne precautions. Because if the patient progresses on to require ventilation, and because of the airborne precautions and anxiety in the staff, we are tending to jump from supplemental oxygen to intubation in our patients. We're not using much high flow or NIV. Once they're on the ventilator, how do we approach it? Well, different to conventional pneumonia, right from the outset, once we intubate these patients, it's very clear we're dealing with ARDS immediately. The way we ventilate these patients is no different to any other ARDS patient. We try and match the ventilator to the physiology. We use as low a tidal volume as possible, starting at 6 mils per kg ideal body weight. We try and keep the plateau pressure below 30. If it's above 30, we go down on our tidal volumes. And we try and keep the FiO2 as low as possible. In our ICU, we tend to target SATs of 88 or above. We titrate the PEEP. One of the differences, which I'll come on to in a minute, is we have to be really careful with the PEEP in these patients. And we're tending not to follow the standard ARDSNet PEEP tables, but we're trying to match the PEEP to the patient's physiology. Normally, when I'm dealing with a post-op pneumonia and I'm putting them on the ventilator, these patients are also septic and I'm giving them fluid. And they'll end up on the ventilator for a day or two. We'll be able to wean them and we're all happy. And because I'm giving fluids, I'm good friends with my surgical colleagues because these are post-op patients and we like to give them fluid. But because I think one of the differences you're going to see when these patients go on the ventilator is because they they're essentially in ARDS once they're on the ventilator, is we tend to practice a bit more of a restrictive fluid strategy. That doesn't mean we don't give fluid, but it means we want to make sure we're truly helping the patient before we give the fluid. And that might cause us to fall out a little bit with each other once the patient's on the ventilator. But what's really interesting and starting to emerge in the literature, what we're seeing in our ICU and from colleagues across Singapore, they're also seeing the same. This is not typical ARDS. And the reason it's not typical ARDS is because we're not seeing a lot of lung collapse, and we're not seeing the poor lung compliance that we normally see when patients get this hypoxic. And it's just some data from the first 10 ICU patients. Once they're on the ventilator, these plateau pressures for ARDS patients with PF ratios around 100, these are pretty good plateau pressures. Normally we'd be struggling to keep our plateau pressure below 30, which just reflects that the compliance is not as bad in these patients as it normally is for ARDS. And that's why we have to be so careful with the PEEP, because if the compliance is preserved, higher PEEPs is not really going to help the patient. And in fact, could be harmful if we start chasing the arterial oxygen with our PEEP too much. And this is just a letter that was recently published by the Italians. They noticed the exact same thing. This is compliance of some of their patients. This is not normal. So normal ARDS patients will have compliances in the 20 to 30 range. 50, compliance of around 50 is actually not that horrible. This is pretty close to normal. And it's not just the Italians, the Chinese have reported this too. And in this study, one of the interesting things and one of the important things why we need to be aware of this with our COVID-19 patients is that when compliance is reserved, our lung doesn't need recruiting. So we don't need the PEEP. Recruitment maneuvers and even proning sometimes may not help these patients. So we have to be extremely careful. The key thing, particularly with the cardiac issues starting to crop up, is we don't want to be giving these patients too much PEEP. So I think just in summary, for most of these patients, if they develop a post-op COVID-19 pneumonia, the majority will hopefully get by just with a little bit of oxygen. If you're gonna have to escalate support, high flow oxygen therapy is preferable to NIV, but again, you've got to be very careful about taking the appropriate airborne precautions. And once they're on the ventilator, we're going to be treating these as ARDS from day one, because that's the way they behave, but it's not normal ARDS, and we're having to be a lot more careful and a lot more physiologic about how we choose the PEEP for these patients. That was my last slide, I think.
Thank you very much, Matthew. We will take the questions again on the chat box for you. I will get my next speaker in. Our next speaker is our associate consultant, Tingwei. She's going to talk to us about CPR, cardiopulmonary resuscitation, what is different in these days. Tingwei, over to you. Are you around there?
Yeah, here.
Lovely. Please, could you share your screen then? Let's get going.
Yeah, can you see my screen?
Yes, certainly we can. It looks beautiful and white.
Okay. Yeah, so I will be talking about CPR and resuscitation and highlighting what are the differences, particularly for COVID-19 patients. So this is the scope of my talk. I will also be highlighting what we do and the challenges that we face for resuscitation of COVID-19 patients. So why are we talking about code blue in COVID-19, or why do we need to even prepare for it? It's because it is a very stressful situation. Even without the COVID-19, it is stressful itself. And the code blue scenario is an aerosol generating procedure. It involves CPR, mask ventilation, and intubation, and it is highly aerosol generating. And the most important thing is that there is this great urgency to attend to the patient, but it is like intrinsic to us that we feel that there's a need to rush to the patient that contradicts the need to wear PPE properly. But we need to change our mindset now that we need to do both properly. We need to wear PPE properly, then attend to the patient promptly, particularly in the COVID-19 suspect and confirmed cases. So this is the guideline published in AHA earlier this month on ACLS for COVID-19. I'm going to go through some detail of this guideline. So essentially, this guideline focuses on minimizing the duration and extent of AGPs, the CPR, mask ventilation and intubation, and also minimize the staff exposure. And by minimizing the staff exposure, we are actually optimizing our resource management. We optimize the need for PPE when we limit the personnel who attend to the cardiac arrest. So it is not very different from what we do usually. We assess danger, and if we see the danger, we don our PPE properly. We don't go into the danger before we don our PPE. The next thing that we do is to prioritize intubation. That is based on the assumption that by intubating the patient with a cuff ETT and having a good seal, we can actually minimize the extent of AGP. So what we do is that once we enter to the resuscitation room, we prepare to intubate. We put on the oxygen mask on the patient while we prepare to intubate to minimize the extent of aerosolization. And in between, we can still give our shocks and CPR, and we then prioritize our intubation once the preparation is done. So the details, how do we intubate the patient? So we want to have the first intubation to be most successful trial. So the intubator must be the most experienced person.
Pero paano, hindi naman yung COVID room ang pinag-usapan natin.
Less viral load kasi kung asymptomatic yan. Kesa kung...
So, pagka gano'n...
Please, could you close your mics, please?
Less viral load.
Please close your mics.
Sa asymptomatic, low-risk patient, tapos nakahood ka lang, okay lang yun na tanggalin mo yung gown na gano'n, naka-scrub suit ka dun sa loob ng operating theater.
Kaya nga yung anesthesia mismo, yung anesthesiologist mismo, i-minimize na yung intubation and extubation. How do you do that? With the wet gauze, with the plastic drape, with the aerosol box, with all the recotitos. Kumbaga, i-minimize mo naman yung aerosol.
Okay, now you unmute. Wait just a minute. Go to the top, go to the top, all the way to the top, all the way to the top. Okay. Okay, Tingwei, you can continue.
Yeah, so we were talking about how do we intubate in a code blue situation in order to intubation. So we recommend video laryngoscopy so that the chances of successful intubation is higher. The other reason of using a video laryngoscope is also to use a disposable scope where we minimize the risk of transmission to the next person. And once we intubated the suspect or confirmed case, we recommend using a closed circuit and connecting it to the ventilator and minimizing the disconnection of the whole circuit. After which, we may want to consider using mechanical compression device. This will at least this will minimize the exposure to at least 2 staff so that we can remove 2 staff from rotating from doing the CPR. So, so what do we wear? What is our PPE for code blue then? So for code blue, it is involve a lot of AGP. So this is the guideline by WHO. So WHO advocate using N95 or FFP2 or equivalent, eye protection, long sleeve gloves and long sleeve gowns and gloves. So this is similar to what we are practicing for our standard exposure to our patient even without the AGPs. So this is another guideline by BMJ. Essentially, it's a similar thing, PPE for AGPs. The minimum standard is N95 or FFP2 along with the gown, eye protection, and gloves. This is a publication by Circulation, again, early this month. I just want to highlight that for confirmed cases, it is straightforward. We will don our PPE, but in a situation where we are called to attend for a code blue situation, we must be mindful that there may be suspected cases that we may not even label them as suspect. So just be mindful that in any case, we need to think about whether we should don appropriate PPE or when should we don what PPE during the code situation. I'm going to move on talking a little bit about our experience in NUH. So fortunately, we have not had any code blue COVID patients in the OT. Our experience are mainly through training, and we focuses a lot about training, simulation, and we use that to improve our workflow and logistic arrangements. So all our anesthetists actually participated in protected code blue simulation. We do it in the ICU setting because all our anesthetists will be deployed to the pandemic ICU. So for our PPE is that we use a standard PPE which involves N95 eye protection, full body gown and gloves for all COVID patient contact, even without AGPs. And for AGPs, we advocate using the PAPRs, provided the users are trained. And I want to emphasize that the doffing process is actually the riskiest process, because when we don, we are fresh and we pay particular attention. But after a code blue, we may be tired, we may be distracted, we may be emotionally involved, and we may not take note of doffing a lot of time. So we just need to be mindful that doffing is a risky procedure. This is the graph, this is the data that we collected in the first 6 runs of simulation that we conducted. We conducted more than 20 runs of simulation since the beginning of this pandemic. So I will just go through this graph. So the blue line at the bottom indicate the time of the first responder to don PPE and attend to the patient before the code blue. So this PPE involve N95, full body gown, eye protection, and glove. This is without the PAPR. And the average time ranges from about 40 seconds to near 3 minutes. The second line is the red line. The red line is the time taken from code blue activation to the code blue responder attending to the patient with PPE and PAPR. So the time taken is ranging from 3 minutes to about 5 minutes. So the varying of PAPR itself does give a little bit of delay. And the last line here, the purple line, is the time taken from time from cardiac arrest to successful intubation. And this timing gives us some clue about how long will the first responder be doing CPR alone, or what do we wear in the ICU setting. So in our institution, because we wear N95 with eye protection gown and glove, even without AGPs, so our first responder can start to do CPR before the code blue response team arrives. If we don't wear the N95, then we may not be able to do CPR immediately, and that will cause another about 5 to 10 minutes delay for the patient without any mask ventilation or CPR. It also tells us that this is a simulation setting where everyone is ready and everyone is just waiting for the code blue actuation and ready to don the PAPR. So when we are ready to don the PAPR, it takes us about 3 to 5 minutes to put it on. But in a real situation, it will take another 5 to 10 minutes extra. So then the first responder nurse will essentially be doing about 10 minutes of CPR alone in a resusc situation. The next thing I want to highlight is actually the trend. So interestingly is that we find that there's significant improvement in the timing after second or third round of simulation, and all the simulation involve new participants that have not participated in the previous simulation. And we think this is because we actually do daily huddles in ICU, updating each other about the common mistakes that we make. And we also change the layout of the setting, the environment to improve our PPE and PAPR donning and doffing. So this is an important consideration with regards to your team allocation or team management. If there is a need of rapid training, perhaps every single team of every shift should consist of someone who is trained, so that this someone can actually spread the information about how to don properly and improve the overall safety of the entire team. So this is what we actually improve on the ground level. So we note that in terms of infection control, the common errors that we make are like we forgot to wear our eye protection, particularly for staff who wears spectacles, or we have poor compliance in the hand hygienes, and so we make we make changes to the layout so that the hand hygiene compliance can be better. So for example, the hand rub at the bottom of the at the room door and just next to where we don and doff off the PPE, we put biohazard bins just next to the doffing area. We also put reflective surfaces or mirror where possible, so that we have so that the code blue team or the staff can look at themselves before they enter to the isolation room, and making sure that they don appropriate PPE. One of the things that we highlighted was communication. So we really can't hear each other when we are in PAPR, or we may not even recognize one another when we are in PAPR. This is a baby monitor, the picture here, that we tried using in our ICU setting. It is good in a non-resusc situation, but in a resusc situation, you may not be able to hear each other clearly because of the background noise. So in a resusc situation, we still use whiteboards to facilitate communication. Apart from that, we do logistic improvements. So to minimize the staff movement, to minimize door opening and closing, we pack items. So for example, mini resusc trolley, IA insertion packages, intubation packages, so that we put things together and we minimize the missing of items and minimize the need to ask for the runner to bring extra equipment to the ICU or the operating theater. This will also minimize unnecessary contamination of the equipment. Yeah, so I just want to end with this. This is a article that is just published early this month. It highlights that in the pandemic, there need to be a change of mindset, that from doing CPR of trying is doing no harm, to there may be significant and potential harm to staff. And in this scenario, doing no harm is not enough. We need to do enough to make sure that the healthcare workers are protected and to ensure the best outcome to our patients. Hence, we need to really identify who are the high-risk patients, and who may have a code blue situation or being unstable when they are in the ICU or operating theater, and start a conversation with the family early so that we can reach a consensus of what is the best risk and benefit in terms of patient care as well as staff protection, so that we won't get stuck in the situation where we need to do CPR on a patient and also risk to our staff. So in summary, healthcare staff is paramount, and we need to prepare for crisis in the midst of crisis. And if we can preempt it, we preempt it. Otherwise, we should focus a lot on training and simulation and improving our workflow to optimize patient care and healthcare worker safety. Thank you.
Thank you very much, Tingwei. As usual, we will take the questions on the chat box, please. I would like to introduce my next speaker. Our next speaker is Dr. Ang. Dr. Ang is a senior consultant with the Tan Tock Seng Hospital in Singapore, which is one of the frontline hospitals that was the initial hospitals managing the outcome, the COVID situation. So he's got a lot of work, and they've published in Annals of Surgery. So over to you, Ang, for the talk.
Hello, can anybody hear me?
Yes, Ang, we can hear you. You can start.
Can you see the slide?
Yes, Ang, we can see the slides.
Thanks, Prof. David Lomanto and Mr. Asim, our ELSA team, for the kind invitation. It's my honor to be involved in this webinar. So today I will talk about the general surgery during COVID-19. So I'm not talking about the COVID-19 patient, but there's some logistic issues with the general surgery during the COVID-19. So these are the contents I would like to cover during this talk. So we all know that we have already over 2 million the COVID-19 confirmed patients with the almost 139,000 people death over the year so far, right? This is a chart showing that we are facing more and more COVID-19 patients in the regions. So this is the COVID-19 dashboard published by the Johns Hopkins, and you will see that this is every day is increasing in the number of the confirmed cases as well as the number of deaths in the entire world. So it's a pandemic now. So regarding before that, we need to understand about the entire healthcare system and healthcare institutions system. So we have a triangle involving the patient, healthcare providers, and resource management. So these are the things we need to consider during the planning of during the COVID-19 outbreak. So also for surgery during the pandemic time, we can also cannot neglect the ethical principles. So these are the guiding ethical principles published by the American College of Surgeons during the pandemic period. The beneficence, justice, fidelity, veracity, and the respect of the persons are important guidelines. Ethical principles need to be observed during the pandemic outbreak. And this is the clinical characteristic and outcomes of the patient undergoing surgeries during the incubation period during the COVID-19 evacuation published by the Chinese group. You can see that with all patients after the surgery developed the COVID-19, and then you can see the number of the patients who have require admission is quite high, 44.1%, and 7 patients die after admission to the ICU, which is the mortality rate of 20.5%. So compared to the normal population, post-surgical operated patients with the ICU management, then there is a risk and increased chance of having the COVID-19 mortalities. So we will talk about the issue about the non-emergency surgical care, emergency surgical care, and then the cancer surgical care in the COVID-19 situations. Okay, so we know that for elective one, We have already have all the governments, institutions, and society has recommended to stop or limit the non-urgent operations. So we need to form the surgical review committee to look through who are the patients, so the elective surgeries, who can be postponed, who are the more urgent cases to be done, and then we need to prioritize and triage accordingly, both for the non-emergency as well as the emergency. Most of the non-elective surgery can be do later, then we try to wait until the COVID-19 is over. So we need to balance between the risks and benefits of postponing the surgery. So most of the elective surgery which are deemed can be postponed to the later dates, then we need to consider postponing to the later dates because of the resource management as well as the manpower shortage during the crisis. We also need to consider the plan in advance for the post-pandemic surge in the elective surgery workloads. Otherwise, we will be in trouble when all the patients become the number of patients become increased when the pandemic is over. The second thing I would like to talk about the cancer surgery triage. We all know that cancer surgery is difficult to be to prolong, to wait until the COVID-19 is over, because currently with the situations, we don't know how long will it take to the COVID-19 to be over. So these are the things we need to consider carefully. So especially for the cancer patients, depends on which type of the cancers. There are post-operative care-based cancer patients who might need the ICU, high-D beds, or high-risk surgery. And in that case, we need to balance between the risks and benefits of the post-surgical complications, and then also the resource needed for the COVID-19 situations. The second we need to know is the delay in the diagnosis, because some of the patients might have the symptoms, but now with the lockdown, with the reductions in the elective outpatient clinics, then it might have a delay in the diagnosis. So how can we inform them? How can we identify them? So perhaps like a technology advanced at the telecommunications or teleconsultations might play a role for those patients who have the symptoms. Otherwise, then once COVID-19 is over, the tumor might be more advanced, or therefore metastatic, and delay in the diagnosis. The second is a delay in the surgery because of the COVID-19 situation, the manpower shortage, resource shortage. So these are the things we need to consider when we plan the triage. We might need to consider about the possible bridging alternative solutions, such as whether can we do the neoadjuvant treatment first. And then neoadjuvant treatment also need a lot of manpower, resources, all these things. So these are the things we need to carefully think through. And sometimes we can think of the stage procedure like a less minimally invasive first for those with the patients have rather than for example colorectal cancers. If you safe to join enough, then we can safe to join. But if there's a risk of the not joining, then perhaps we should just put the stoma first and then join back later. So these are the things we need to carefully plan before the surgeries. We need to be aware of the potential complication from the surgery, and then after the complication and the patient have a COVID-19 after the surgery, then what are the things we can happen? So these are the things we need to think through, and then we need to liaise with the patients and families and communicate, and then also to get the informed consent with the proper communications. These are the important things we need to observe during the crisis. The second is, of course, with the social distancing, and then the no meetings are allowed. So the technology-based, the online meetings on the virtual tumor board, MDT, to be done, so that at least the patient care is appropriate when we meet for the tumor board decision kind of situation, so that we have a shared decision making for the better interest of the patient. So how about the emergency surgery? So during the emergency surgery, I can probably think of the three possible patients in the COVID-19 situations. One is the COVID-19 patients already warded for the COVID-19, maybe in ICU or maybe in the high dependency units, and then develop the surgical emergencies because of the condition. The second category will be the surgical emergency patients with the concurrent COVID-19 infections. Then the third is acquire COVID-19 post-operatively, or they were asymptomatic, or they were not tested positive. I think earlier speaker showed that when they tested it, there's a 20% chance of the negative, false negative. So it might develop the COVID-19. So we need to have a due diligence care in the preparation of the surgery for the emergency conditions. So first of all, we need to think of the best interest of the patients, no harm to the patient, and also the greater to the situation as the institutional resources. The staff and other patient safety also need to be considered during the planning for the emergency surgery. And then in the end, it's the entire healthcare system and what is the best benefit for the health system perspective. So for example, a patient have appendicitis in the situation, can we still conservatively manage the patients? For example, acute colic patients, can we still observe the patients with the conservative management? If the situation allows, of course, we can consider them to slightly subacute care of surgery, or we can conservative management first until patients. So, but we need to be mindful that we cannot let our guard down that, okay, these patients need the emergency surgical care. So we need to be very careful in our decision-making process. So this is an intercollegial general surgery guidelines by the UK groups. So for them, they recommend that the emergency surgery to test all for the COVID-19. I think that this is maybe we may not able to do that. Need to treat all as a positive, so that we need to, this is what we can do, because we have to make sure that everybody is PPE gown. If patient especially patient have the symptoms, for those patients we need to do the CT abdo-pelvis. Perhaps we can consider doing a CT thorax just to exclude that possibility of the COVID-19. So especially for those with the symptoms, we need to be, probably we can screen them. There's a possibility of COVID-19, and then we do the full precautions measures before the surgery. So I think the previous speaker has already mentioned about the theater setups, minimize the stuffing. Hopefully the most senior person or most appropriate person to do the surgery. It's not the time for the training. And then also try to get in the negative pressure room if the COVID-19 is confirmed positive. And also consider about the smoke extraction, and then the intubation, extubation are the things we need to be careful during the COVID-19 patients situations. And then for the planned surgery, we need to risk assess for the COVID-19 again, and then whether it's a greater risk for surgery, like I mentioned earlier. And then the other things we need to consider is laparoscopy. Usually they say the laparoscopy should not be used, but evidence is not very strong. So I will go through the SAGES guidelines later part to see whether laparoscopy is still feasible. And I think Mr. Asim will talk about the laparoscopy in details. So this is an updated guideline by the same Royal College surgeons, together with the August and then the ASGPI, about the recently published on 6th of April 2020. So what they suggested or advised is that for acute patients, COVID-19 should be sought in any patient if possible by going through the thorough history taking and then the physical examinations. And then if needed, we might consider to the COVID-19 testing to confirm it. And then for those patients need the CTAP for abdominal pain or acute abdominal symptoms, probably we should consider to the CT chest at the same time to rule out the possibility of the COVID-19. So for those patients who need the urgent, but it's a planned surgery, means a semi-elective kind of situations, if possible, we can self-isolate them and assess for the COVID-19 if needed. Is a high-risk patients or highly suspicious, we could probably consider testing the COVID-19. And then after that, we can consider whether what type of the surgery is more appropriate for the patients, especially considering the risk of the possible COVID-19 situations. For those with the aerosol generating procedures, either the COVID-19 is suspected or confirmed, we need to do the full precaution for the PPE to protect ourselves, to protect from the cross contamination to the other patients as well. The other is the laparoscopy, as I mentioned earlier. There are some risks of the aerosol type formation and infection, but it's not strongly evidence-based. So the level of risk is not clear, and then the level of the PPE deployment may be important. So some of the advocated safety mechanisms like a filters, traps, scaffold deflating, it is still difficult to implement. So it seems the laparoscopy, the energy device usage can create the aerosol type formations. Laparotomy together with the coagulation instrument may also be risk. So in that case, we need to have a universal precautions with the protect staff, protect the other patients. These are the important things we need to be observed during the situations. This is the SAGES and EAES joint statements and guidelines provided in the COVID-19, I think the end of the March 2020. So in here, you can see that the personal protection is important, service need to be rationalized, which I will touch upon. Laparoscopy is a little evidence of the MRS risk specific to the COVID-19. The proven benefits of reduced length of stay and fewer complications is well known. So that it will also properly consider for those with the appropriate patients because it will not stress the system. For example, COVID-19 patients, I mean, for the MRS has a less chance of the wound-related implications, shorter length of stay, shorter nursing care, less nursing care. So in the crisis, we need to address it whether both patients are still laparoscopy are suitable or not. If it's suitable, we can do the precaution measures, and then we might still consider doing a laparoscopy. I think Mr. Asim will go into details, present details for the laparoscopy in the COVID-19 situations. So this is stages. There are recommendations. You can see that with the benefits of MIS and reduced length of stay, we can still strongly consider we need to balance between the risks and benefits of the MIS procedure, even though. So this is a summary of the commercially available smoke evacuation systems we can consider. And this is recently published by the EAES group about the considering for during the resource limited conditions. We can use a simple using the filter, which is certified for 99.9% effective protection against the Hep B and Hep C virus, which have a diameter of the 42 nanometer to 30 to 60 nanometer. With the SARS-CoV virus has a larger diameter of 70 90 nanometer. So perhaps we can probably consider as this kind of low, safe and effective method for the precautionary measures to prevent from the aerosol generating laparoscopic procedures. So in summary, I would say appropriate PPE is the most important, and then we need to balance between the risks and benefits of surgery or not doing surgery during the pandemic period. Well-informed consent, including the risk of the COVID-19 together with the surgical complications, is still very important. Proper communication with the patient and family is paramount. And then we need to think very careful about the resource management, especially looking at the entire institution as well as the entire healthcare system resource limitations to be considered. The most important thing is that we need to protect the patients, our own healthcare members, and other patients, whatever procedure you do. We need to get the hospital surgical review committee for the prioritizing and triaging. So in Doffing Hospital, we have a chief triaging surgeon together with the committee involving the anesthesiologist, also the senior nurses to help triage. And then so for each individual, surgeons will try to justify what is the reason we need to do, and then we will triage, especially for the elective patients. Then after that, we will go through the respective head of department to approve. Then it will go to the central committee to approve. So this is a process we need to go through, so that if everybody is playing part and then it's justifiable, then there will be less work for the review committee. So this is something we can do to help. And then the review committee will decide on all the complete picture of the situation in the institutions with the resources and then the time. They will try to help whether we can increase the number of the cases or number of the OT slots, etc. So we need to consider virtual online and video meetings and not to compromise the patient care, especially for the cancer patients. So we need to also understand about the potential risk of infection created by the aerosol procedures during the laparoscopy using the energy devices. I think there will be another talk on the energy device later. So in the end, we need to plan the post-pandemic potential such of the surgical workloads, and then we need to start planning how can we tackle them and how can we increase the workload after the pandemic. Thank you very much.
Thank you, Ang. We will move on to the next one while you take your questions on the other side, on the chat box. Thank you. I think, Ang, if you end your slide presentation, I can post on mine. All right, so I would just go on. I'm not going to put my pictures on and all that. So it's laparoscopy, all you need to know about MIS surgery. Can you hear me? I think the history bit of it has been dealt with everybody, and so this is a detailed history. As the slides go by, you can share this. This is basically epidemiological information, demographic information, and some clinic history that needs to be collected from COVID patients or those that you're screening through. And Jyoti went through this very nicely. So what is laparoscopy? The controversy between laparoscopy and open surgery, is it really sorted out? The answer is no. Nobody knows the real answer, whether we should still be doing laparoscopy surgery. And I think it is important that we individualize the approach and the timing of surgery by balancing the risk of disease progression, i.e. if you wait and cancers or inflammation progress, and the risk of surgery and aerosolization, that really makes a difference. I think I like this indication, as I had mentioned in my previous talk. This is from the American College of Surgeons, and it says that goal is to provide timely surgical care with optimal patient care resources and preserving the health of caregivers. So everything, you have an onus to the patient, you have an onus to the caregiver himself and to yourself to provide a safe surgery. As long as you can balance these tripartite missions, then you're actually doing well. Because if you do laparoscopic surgery, we know we have a shorter length of stay, we have a lesser readmission, lesser harm to patient, but then there is an increased risk to staff potentially, and obviously for patients who have failed medical management, then surgery, whether that's open or laparoscopic, is indicated. So I think the brainchild behind all this is the surgeon himself. We all train from novice to become expert, and this is really where your expertise come in, assessing whether you can create that balance with laparoscopic surgery. But do remember that the risk of aerosolizations are higher in laparoscopic surgery. So this is just a simple video, and this is an open bipolar diathermy, and to show you that even in open surgery, there is plume formation. So if you go away with the impression that plume will not form in open surgery, that is wrong. Trocar insertions are great. You can use these trocars which have balloons at the end, and they will hopefully prevent a leaking port. There are other ways of using system. This is an air seal system. This is called the ConMed air seal system, where it is sealed. The air circulates in the trocar here and does not let it escape. The utilization of carbon dioxide is less. The pressures are operated at very low. The smoke evacuation mode allows to smoke evacuate. So these are, and the filter at 0.01 micro ULPA filters, which you can see can actually cover COVID filters as well. Try and use disposable instruments where possible. Why? Because on reusable instruments, there is consequence of residual viral load. All right, and try not to use disposables as reusables. As you can see here, despite cleaning them, you will still have a viral load in presence. Can you use reusable instruments? The quality of the instrument, one, reduces over time, and because particulate elements and aerosolized things can be left within the reusable instruments, the risk of having or breaching sterility is higher, and thus conveying infection is higher in these patients. Reduce the Trendelenburg position when you're putting patients in pneumoperitoneum because it may compromise respiratory function. Obtain minimal pneumoperitoneum at low flow at pressures of 10 or 12 at the max of millimeters of mercury. Try not to increase, because as you increase pressure, it decreases the abdominal and the lung compliance and also increases the chances of leak. Pneumoperitoneum, try to ensure that you use them using clean trocars, and the incision sites are small so that they can be airtight. When you do that. And I think one of our great speakers, Mahir, is going to speak about, if you don't have these fancy trocars that I talked about, how you can create a very nice air seal, and I leave him to do that great job. Now, this is to show you that even a simple ultrasonic energy device also generates plume. You can see this plume that has been generated by an ultrasonic device. So we take care of this. So what do? You basically suction more frequently so as to keep the field. Use HEPA filters, and I'm not going to go into the details as Davide will talk about this. However, the ULPA filters are able to clear coronavirus, although there is no level 1 evidence to this. It's just based on size. And this is how it looks like. This is the rapid evacuator or the SOM evacuator system. And this is how it looks like in our theater. And again, I'll leave David to deal with this. So managing surgical plume, all pneumoperitoneum should be safely evacuated via filtration system, as you saw. Before closure of trocar removal and extraction and conversion to open, empty the abdominal cavity of whatever pneumoperitoneum is there. Just don't make an incision and let everything fall apart after doing laparoscopic surgery. Avoid long dissecting times, do shorter operations, avoid sharp injuries to your protective equipment as well while passing instruments. Instruments should be clean and blood-free. Use slow short burst of energy, because the more longer you burn, the more longer the tissue goes from a coagulative mode to a charring mode, which generates more plume. And remember that the low temperature of the aerosol does not effectively kill the virus. Concerns with MIS basically are droplet, contact, and as Somani mentioned, and I would like to stress here again, that fecal-oral route is important. And when we do GI surgeries and burn tissues in GI surgeries, we can effectively aerosolize these tissues, and they can actually be a source of infection. So it's not that the virus does not live in the GI tract. I think Raj will deal with this active COVID-19 thing. Last but not the least is occupational hazard teaching. Please educate your people, practice proper techniques, strengthen an awareness of hazard caused by smoke, management of intraoperative aerosol. Strict protocol must be established for the creation and maintenance of pneumoperitoneum to reduce the occupational hazard. So exercise clinical judgment. This is the most important time where you can differentiate an expert from a non-expert, and that's why all COVID surgeries or in suspected cases or high-risk areas should be called on by the specialist to do. And there is insufficient data as of now to recommend against or for open versus laparoscopic. So exercise clinical judgment again. I come to the end of my talk with that, I think. Let me do that, please. Thank you very much. I will take questions through the chat board, and I would now ask Monsieur Davide Lomanto to take over the chat board.
Are we ready? Is my video on? My voice on? Everything is on?
Very good. You are perfectly heard and perfect.
Excellent. Thank you very much for being with us so long. I think I learned a lot today. It was quite useful. I remind that we will upload everything on YouTube. We really apologize again for the mishap at the beginning, but we will sort it out with the next webinar. Why we are talking about energy? Because I think it's impossible to do procedure today without the use of diathermy machine or advanced energy. And what is the main issue? That the coagulation, the effect of hemostasis done through evaporization that create aerosol and create a surgical smoke other than OR5 that at the end of the day are harmful to the OR staff because the bioaerosol may contain bacteria, may contain virus, may contain toxin. So we need to use. And we don't need to use only today because we are talking about pandemic, but we should use this system even during the normal surgery. So filter and smoke evacuation should be implemented. We have a cheaper and more expensive device because we know that surgical smoke are toxic, even for us, open surgery, but we don't care much. So at the beginning of COVID-19, there was soon, of course, many society associations come up with some rule and regulation. There was no base on any evidence-based medicine, but only create panic because there was an hypothesized risk for aerosol, especially towards laparoscopic. We should consider also open because they create the same system. So the risk, there was a bit of alarm, but after that, especially here in the NUH with Asim and Raj and other team, we were thinking about how to overcome this problem. And we look at the scientific point of view and we see, and we all know that the size range of the virus is between 60 and 140 nanometers and can be found everywhere in the respiratory tract, the GI tract. So we need to consider that all the patients, even asymptomatic, are potentially positive and carry. We saw from the slide before, even multiple swabs can be positive and negative. So we should have precaution all the time. So the virus is everywhere. There is a risk of aerosol exposure for the operating team, can come from the intubation, from the surgery itself, for the use of ultrasonic scalpel, electrical equipment. And we know that the temperature for example, from ultrasonic scalpel doesn't deactivate the virus because there was a tendency, okay, we don't use diathermy, we use ultrasonic, but was not confirmed. And of course, for laparoscopic surgery, since we use a CO2, the risk of aerosolization from smoke evacuation for the trocar valve is much higher. So we look at what is the potential, and we know that we have in the market two types of filters. The HEPA filters that can remove particle or contaminant that are smaller as 0.3, so 300 nanometers, that are the one who are normally utilized for the OR filtration. While the ultra-low particulate air filter, the ULPA, can remove almost 99.9% of contaminant with the smaller size, that is the same size of the COVID-19. But of course, there was no study, no proof. But hypothetically, we can say the ULPA filter works with the COVID-19. What kind of filter do we have and we can use? Because we can have a passive filter, so filters that are not connected to any evacuation machine, but they just work in a passive way. And we have few filters in the market, millipore, plum away, and the other filters that can be utilized in all with connecting with the standard insufflation tube to any outlet valve. And we can connect to the suction canister, just like we do for chest tube, same system. Plus we have more expensive device that are active smoke evacuator. They compensate between the in-patient and in pressure and out pressure. And they're all equipped with the ULPA filter. So they work very well. Most are reusable. The cartridge, you don't need to change all the time. We have, several ones from AirSeal, Megadine, and Covidian, and so on. But I want to also highlight that even for open surgery, we have a suction device. You can see a small cannula that it can be attached to the open surgery device, to the pen, and can be connected with the active. We cannot use a passive in this case because we need to have an active evacuation. So In the end, I think laparoscopic may reduce the risk of intraoperative exposure to smoke because it's a closed circuit if we properly done, compared to open surgery that is an open space. But we need to use smoke evacuation device and cleansing. So if we want to say, I would like to summarize with some recommendation. First of all, we need to use an operating room that have positive pressure, that's equipped with HEPA filter. We need to avoid gas leakage around the trocar. As Sim was showing some of the trocar, we can use suture. We can use a smaller wound incision. We need to use a lowest CO2 insufflation pressure. Cannot be, I cannot say it's 13, it's 11, 12, because it depends on the conformation. If the patient is thin, even 9 give you a good space and working space to do. Use UPL filtration device, either passive or active. Connect all the trocar valve to the smoke evacuation device, all, not one, because I say I will not use because we don't know. At the end of the procedure, you need to evacuate the CO2 through the filtration device. You need to remove the specimen after the gas has been evacuated, and mainly avoid to use any drainage. Nobody talk about this, but drainage as a source of infection because virus is there. So be safe, be healthy, and join us for the coming webinar that will be every 2 weeks. Thank you very much, Asim. Asim?
You are still the host. Can you, David, you're hosting the meeting, so do you mind giving me the host rights back?
Are you sure? No, you are hosting. Okay. I just stopped the sharing.
Okay, thank you very much, David, in that case. And I will now get Raj Menon back. We'll be fairly quick. We're going to talk about risk mitigation post-surgery.
Hi, everyone. Just to share a little bit more on Hi everyone. I'm back to just share a little bit to conclude this segment about risk mitigation post-surgery. And this is based on our own experiences as to what happens and how to reduce risk in exposure to staff and surgeons post-operatively. I think a lot of what we're going to talk about has to be customized to the country we are in. In Singapore, we have a limited community transmission and very strong contact tracing abilities, which is why we are able to actually pick up cases relatively quickly and try to risk segregate them to which are high risk and low risk. So what I'm going to talk about now is actually in the next 2 or 3 slides is simply the context in Singapore. It may not be applicable to your country, especially if there's very widespread community spread and unlike the situation in here where it's a little bit more contained. Well, I think one tip in risk mitigation and starts with prevention. And in prevention, I think the thing which is crucial is basically to try to identify these cases early. Now, we found that normal history taking tends to miss a lot of the contact and travel history and association, and even history of a respiratory illness, especially in the context of surgery, simply because patients don't think about that. They will be presenting with the abdominal pains and the other symptoms, and sometimes we have to assess at multiple time points and multiple periods to get this history of respiratory infection, fever, as well as contact and travel. So back in your own hospitals, make it a protocol that both at the emergency department and the general ward, at every point of patient contact, that you reassess this so that you can pick up cases and you don't end up with cases at the operating theater door when you suddenly realize, oh, this is a patient who has got a significant risk and who I would have wanted to swab and perhaps even operate in a COVID theater. So that's one. The second group of patients where we presume that they may have an infection until otherwise are sometimes those where we cannot get a history from. For example, in Singapore currently, we have an issue with our foreign workers and our construction workers all having a large spike in the number of cases. When patients come in through the door, let's say in the trauma situation, after road traffic collision, when we cannot get this history, we presume that these patients may be positive, may be suspect or positive cases, and we adopt a full PPE for these patients because we're not able to clear them with a good history and collaborative history. So this is one aspect in prevention. If you're not sure, presume the patient is. Second thing is, of course, and I think this has been discussed before, is first of all, review whether this patient actually needs surgery. There's a whole bunch of non-operative, interventional radiology, pharmacological techniques that you can use to treat many surgical conditions, including appendicitis, cholecystitis. And in this period of time, consider whether in the first place you should bring for surgery. It's not business as usual. Try to see whether you should stratify your risk decision making. And the last part in prevention is make sure your staff, again, we've talked about PPE time and again, make sure there are refresher courses. Even the elderly surgeons, people who have been operating for years, they may have forgotten, get them retrained. Now, what happens when you have a patient who's gone through the system, but you operated on them without the adequate protection, or you only realize that this patient has a contact or is a COVID positive patient after operating on them without the full PPE? What we do in our hospital is first, we activate our epidemiology and occupational health and infectious disease teams, number one, and we notify the Ministry of Health. A detailed contact tracing is done of the entire chain of doctors and clinicians and nurses and staff and porters and security who have been involved in the care of this patient, all throughout their chain from A&E all the way up to the ward and OT. And based on that, we assess what kind of PPE were they wearing. If a doctor was wearing appropriate PPE for that duration of the procedure, then they are just considered as a protected contact, and as such, they will still be allowed to work and just continue with temperature testing and clinical management and clinical monitoring. If they have not met the criteria, for example, they were not wearing PPE at all and encountered this patient and they operated on them, or they had them in the emergency department, or if they were doing an aerosol generating procedure and they were not wearing an N95 mask, for example, or goggles, then we would insist that these patients take a leave of absence with temperature monitoring and review of clinical symptoms. We don't swab them directly unless they become symptomatic, but we keep them away at work and we mandate that they don't turn up for 2 weeks until they are clear. So this is a very time-consuming and difficult process, but it's very important to limit healthcare worker spread. You really need to trace down exactly who has met the patient, and as well as what PPE they were using. And sometimes when there's recall issues, we presume that they haven't assumed that level of PPE. But if they have been wearing the appropriate amount of PPE, and even if they operated on this patient not knowing that he was a COVID positive patient, we are happy, we trust our PPE, we're happy to continue work. If not, you'll end up with quite a bit of staff loss and resource drain if you indiscriminately put everyone out of work as well. So this is a balance between continuing services as well as staff safety, and every institution has to review this and discuss it with their staff. If there's a patient that has slipped through the cracks, it's often useful to go back and reevaluate where this gap occurred in the whole system so that you can make adjustments to your system during this time of change. We also risk mitigate by segregating our staff. We maintain different teams which don't interact. So if we have 4 hepatobiliary surgeons, we have 2 on one team, 2 on the other, and they never interact and they don't meet, and they haven't been meeting for the last few months. While in order that in case one team goes down, we still have backup, and also not to deplete the entire capacity of our surgical team. Even within teams, we try to maintain social distancing. We maintain mask wearing in every part of the hospital, including the administrative and non-clinical areas, and we try not to break this team segregation as much as possible. And I think a part which we never think about much is also to monitor the overall workload and work strain, because people will start taking shortcuts, not wearing correct PPE, for example, when they are under strain and if they are overburdened. Regular surveys for burnout and for their own level of work is important, so that administrators and leaders can then make adjustments to the work processes. So this is a part which we don't really talk about, but it's really quite important. So that's all I have, and these are the main strategies that we use in my hospital. To conclude, misses will occur. There will be sometimes gaps and things will occur, and it's important that you talk to your departments so that they know that these are the plans to risk mitigate. When people are supposed to be at home, enforce it, make sure they don't come back. And again, the last point, limit the departmental effect of any spread with clear segregation policies and burnout monitoring. this is a complex topic more than the scope of just these 5 minutes, but I'm happy to take questions in the chat, and I will leave my email there as well if you want to contact me offline with further questions. Thank you very much.
Thank you, Raj. While Raj goes offline with his presentation, I think it's important to understand risk mitigation because it plays a major part in the way surgeons and communities behave. We'll move on to our last speaker. Our last speaker is Professor Mahir Osman. Professor Mahir is basically professor of surgery at the Istanbul University in Turkey. He is a surgical oncologist. He is the president of the Bariatric and Metabolic Society of Turkey. Very well published, very well known for his work, and he amazed me by all the tips and tricks he gave in the last presentation, and I think he's going to steal the presentation today as well. Dr. Mahir, Professor Mahir, over to you.
Thank you. Can you hear me now?
I can hear you clearly.
Okay. Thank you, Asim, and thank you, David, for the invitation again. That was a long morning on my side because we started 6 o'clock in the morning on this side of the world. I will give you some brief information on what you need to do during the COVID-19 pandemic as a laparoscopic surgeon. Everything is actually well explained, and I cannot actually change my slides now. Can someone help me to change the slides? Yes, I can do that now. We published 2 papers on the what you need to do as a surgeon during this pandemic. You can actually get an access on that papers through the connection I am showing here now. And also you can follow the guides as shown by other speakers on what you need to do during laparoscopy. But I have to say that that's all are being changed now, and there are some changes on the guidelines as well, so you need to check regularly on the websites. And what I will do now is I will show the video of how you need to get ready for the operation and which kind of equipment you need to use during preparation of the surgery. And as you can see here, we are using this is a gown, special gown. This is my assistant professor. He's taking this preparation, putting the guide on, and he's using N95 mask. And as you can see here, he covered everything. He's gonna have the glasses, goggles, on top of the mask. We always use boot, and we will put another mask on top of N95, and he's gonna have special cover on Google as well, and then scrubbing up using brushes, and then the getting ready for the procedure. It's all regular that you are doing every day, and then he's going to put the apron on the special gown and get ready for the operation. So we're going to use double layers of the gloves for the operation. It's important to cover and to protect yourself from any kind of contamination. And when you're finished, you need to take everything off in an order. And you need to leave the first layer in the theater, in the special bin in the theater, and then take the other layer outside of the theater. So you can see here, he's taking these things outside of the theater. And after taking the special white cover, he's gonna take his scrubs outside the theater. And then he will finish cleaning and changing all that equipment, and he will leave everything in a special bin to discard. So this is the video that you can use and check regularly. And I would like to thank Emir again for this preparation for this video. And if we get a summary of what we are using as a special equipment, as you can see on this slide, which is already spoken and given details of other speakers, I will not go through that. I would like to talk about how to protect the leak and the virus contamination in the theater during laparoscopy. We have some special industrial available, commercially available systems, but they are quite expensive. As you can see, this from CONMED and this from Etikon, and the other one is from stores. But if you don't have any kind of this equipment available in your theater, do not worry. And what we are doing in our side is we are using this MF line that we are using in the wards and in the ICUs to connect our trocars to suction irrigation bin, which is filled up with a disinfectant, and all the CO2 during the procedures, if there's any leak, will go inside this bin, which will be discarded after the operation anyway. So you can follow the photographs, and I will show you the video in a minute. You can follow the photographs and you can see how we made the connections here and how it is connected to bin outside. And you can see that there is no leak on top of the suction irrigation special bin here. And I will show you the video how you need to desufflate the patient. When you finish the operation, before you start desufflating, and when you finish desufflating, before you take your trocar out, you have to close the line by using special staple and make sure that nothing is going to go outside, as you can see here and here. So this is this short video to show you how to take your trocars out and how to take your camera out after disinflation in order to avoid any contamination through the CO2 coming out into your theater. And it's much more cheaper than that kind of systems, and it's quite useful. So when you finish this, you will see inside and you will check the trocar size first. After desufflation, take your trocars out. No air left inside. It's already disconnected from the insufflators. So you are seeing that we are taking trocars out by seeing through the camera. And then at the end, the last one is the camera trocar, which needs to be taken out properly. Okay, and then when you finish it, you will see that there is no leak outside. So this is the summary which is already given by other speakers. I will not take your time to go on through that, but I would like to press on this paper, which explains the rate of death in patients undergoing surgery during the incubation period of COVID-19 infection. If you check this paper, you will see that the rate of death is around 20%, 20.5% in the patient, but it's especially increased in patient with pneumonia. The death rate is around 50%. So you have to cancel or you have to postpone all your elective operation during this period of time in order to avoid unnecessary results and lose your patient. So this is the summary. Again, this is the summary how to choose which kind of surgery and how much actually you can delay that kind of surgeries. It's already shown on the table. You can check through that paper published by Style on patient safety in surgery. I'm not going to go through on that, but I would like to mention about our study, which is being run since the pandemic started. Most of the health personnel in my hospital is actually participating in this study, and study is actually going to be given to bigger population now. What we are doing is we are using pleconil 200 milligram once every 3 weeks, which is combined with vitamin C, vitamin D, and zinc. 3 of them are actually available in one drug from Bayer, Redoxon, effervescent, once every day. So 120 participants by now are using it. Most of them are actually personnel, healthcare personnel, and doctors and nurses, and their first degree relatives if they want to join. So we haven't seen any infection by now, which is 2 periods of time is already gone, and they're gonna have 2 or 3 more periods. We checked them by using a rapid test, and I have to say that no one is infected. And I'd like to thank Asim and David for giving me this opportunity once again by showing you a great picture from Istanbul. And would like to have you all in Istanbul after this terrible time passed on. Thank you very much, Asim.
Thank you, Dr. Mahir. And as I said, you would never fail to enjoy Professor Mahir's talk, and I absolutely enjoyed it. I've listened to it so many times, but every time I learn something new. Your innovative way of doing a chest tube and using it down to filtering viruses, great work. I must say, I think it's of great help because there's so many people across the globe who may not have access to technology. And I saw Mahir go through these videos and I thought this is really worth sharing. Thank you. Since Professor Mahir is the last speaker, if there are any questions, we can ask him directly. If there are any questions for Professor Mahir, please let me send them on the chat group and I will ask Professor and we will answer it straight away. So you have a comment from one of our speakers, Professor Dr. Raj Menon, who said, super inspired by your innovations. Amazing. So another comment for you, positive comment. So great work. I think while we wait for those questions to come, I would pass the mic back to Dr. David Lomanto for the final closure. Another comment for you from Mike Filona. Great work. You've done a great job.
Actually, Asim, I want to call in a few people. I think Maki will be great to have your comment on your experience in the PGH. Like last 2 weeks ago, also we called Maki in. Maki, can you hear me? Wait, let me check. Maki.
Yes, David.
Yes. Oh, wonderful. Where are you? You are in Chocolate Hill.
I'm in Bohol.
Bohol. Nice background. No, it's a fake background.
Yes.
Mikey feels like doing.
So
Maki, I know you very active on the chat. So any comments?
Oh, great lectures, everybody. And we are basically doing the same thing here now in PGH. We are actually starting to prepare for our elective cases that might have to start by May 4. So we're doing the processes now for preparation for our OPD, for our operating theaters. The operating theaters have already been set up to have a non-COVID and a COVID area. So we'll probably start with our old patients and our malignancy cases first, gradually escalating to, we'll see how much we can accommodate. But despite the escalation, we still have to do the social distancing and the safety for the healthcare workers.
I think now all over the world we are looking at the phase 2. In Singapore, we use orange, yellow, red. So we are still in orange, but if we can, actually in terms of community spread, as Raj say, we are quite low, but we have a lot of foreign worker. I didn't get that. Could you try again? Foreign worker contamination. So as soon this phase will be over, we hope to go back to yellow, in which at least kind of day surgery, partially elective can can be done.
Professor Mahir, there are two questions for you. Do you have any special guidance for patients on pediatrics patients?
I have no experience with the pediatric patients as I'm a general surgeon, but I can say that you can actually use the same kind of system for the pediatric patient also.
Yeah, I would agree with that. Our Department of Pediatrics is doing the same. They are following the same protocols as we have suggested for the other ones. There is another question. Would Veris needle be a safer option than Hassan Trocar for insufflation? What are your opinions, Professor Mahir?
Yes, I mean the important thing is you should need to use which kind of way. It's not important, but you have to use the technique that you get used to it. So don't change your technique just because of the system. Otherwise, you can end up in terrible complications like having injuries on the organs or putting your Veris needle inside the aorta. So if you follow the rules, and if you don't change your technique or your habit because of the coronavirus, that's fine. But I believe Veris needle seems better in this kind of situation.
Thank you. I think words of wisdom, do not change your technique because it makes a lot of difference. I think that's the crux of it. Professor Mahir, one last question from Ike Mendoza before we let you leave. What is the disinfection solution you use in the suction container? Is it a varicidal? What is it?
Sorry, repeat again?
You showed that solution into which you connected your exhaust tubing. What is that antiviral solution that you're using there? What are you using?
This is the solution that we are using all the time.
Do you have a name for it? Do you know what it is? He wants the name.
I lost my...
That's okay. I think for that purpose, any virucidal solution is enough. I think even soap can kill the viruses. So it is good enough. Whatever virucidal solution you have is good enough.
It is Sidex that we are using. Yeah. The name of the solution is Sidex that we are using all the time.
Thank you. Thank you.
Okay. Asim, before closing, I want to, I saw that among the participants, today we have our past president of ELSA. Alan, are you in? Can you give us a word of support?
Yeah.
Hi, we want to see you. Where are you? On the beach?
Alan.
No, I cannot open my video. I'm clicking on the video. You need to unlock my video.
No. You can do yourself. On the bottom left, there is a video.
Yeah, I know. I'm trying to do it, but it won't. I don't know why. I'm trying to unlock the video.
Think when you log in, probably you know activate the video. Anyway, you can listen to you.
Yeah. Anyway, congratulations, Mahir. Very nice lecture, David and Asim. We would like to thank David and Asim for organizing these webinars. I think it's due, right? Yeah, very time. The timing for the lectures are very good because there's a lot of questions on when, and how do we do surgery, especially in this time of pandemia. Anyway, we expect for the next one to have a better, connectivity with everyone. Everyone has a lot of complaints on they cannot connect with the webinar because the participation only limits to about 100. Next time, in 2 weeks' time, I think we can come up with a better solution on how other people can connect with us. Anyway, the webinar today has been recording. We were recording it. We promised all the other participants that we will be posting it in our Facebook account, and they can follow us in that Facebook. Congratulations to all the lecturers. We learned a lot from this webinar.
Okay, thank you, Alan. Okay, now before concluding, let me thanks all the speakers, Omani, Raj, Razali, Brian, Tengwei, Matthew, Ong, and Mahir, of course, because he's already with us 2 times. He's part of the organizer. I will pass the microphone to Asim to conclude and enjoy the weekend.
Thank you very much, everybody. Thank you, David. Special thanks to all the participants because of whom this seminar has been possible. And we look forward to many more from ELSA. As you would have received the list, we are trying, these are not necessarily related to COVID, but we are going to make this more educational. So your participation actually gives us the boost. We apologize for the glitch that happened today. It won't happen next time. We had some technical problems and we will sort this out. For purpose of completion, the recording of this will also be posted on Facebook. It will be on YouTube, but you can access it on YouTube through the ELSA app, which can be downloaded onto your iPhones or Android from the respective stores. So please do download them. If people want links to them, we will put the link there. You can all get it. And we will see you in 2 weeks' time. Thank you very much and have a great weekend. Thank you. Thank you, everybody.
Thank you.
Thank you.
Bye.
Keep safe.
Bye, Maggie. Oh, now
nice
you really. Oh, you are laid down, Maki. Yeah.
I'm in a sofa.
Good idea. Hey, enjoy. Take care. Thanks a lot.
Bye. Thank you, Mike. Thank you very much. Bye.
Bye.